fluorosis except one. Which one is the exception? Now, before we look at these answer choices, let's just talk about what fluorosis is. Now, fluorosis is an excess of fluoride during tooth development that causes enamel hypoplasia or hypocalcification, which is just incomplete or defective enamel formation. Now, hypocalcification is less severe and it's much more common. In hypocalcification, we see these chronic, moderately high levels of fluoride during the pre-eruptive maturation stage of enamel, and it causes some disruptions in this enamel crystal formation, and it causes disruptions that can lead to this chalky white appearance as well as weaker enamel, and we see that in the picture on the left. Now, when you have these very high levels of fluoride during an earlier stage, the secretory stage of enamel formation, you'll get a more drastic hypoplastic effect, such as pitting and disturbances in enamel form, and we see this more on the picture on the right. It's more severe. Now, a very important thing to highlight is that fluorosis can only occur when your teeth are developing. So me as an adult, if I ingested a lot of fluoride, my body might have some effects, but I wouldn't see dental fluorosis as a result because my teeth are already fully developed. And the fluorosis severity and incidence that we see in a patient is correlated with the amount of exposure during tooth development. This determines if it causes more hypoplastic or hypocalcific effects. Now, clinically, as you can see from these images, the symptoms range from mild white mottling to severe pitting and brown staining. Usually what happens is your tooth will erupt white, but then it'll stain brown due to extrinsic materials getting stuck in the pitting of that tooth. Now, the effects of fluorosis are usually seen in a few teeth because your certain teeth will calcify at the same time. So like certain incisors will calcify at the same time, your canines will do the same, so you won't usually see this in one tooth. It'll usually be among certain types of teeth. You'll see it in more than one tooth, as you can see in this image. And also one more thing that I want to highlight is that fluorosis is not entirely consistent or predictable. Some people are more sensitive to fluoride than others. So two people could be exposed to the same amount of fluoride at the same age, and you might only see effects in one of those patients. Now let's look at the answer choices for this question. It's asking, which of the following is a risk factor of dental fluorosis, except for one? Which one is the exception? So we have fluoride toothpaste, fluoride supplements, use of infant formulas, and drinking bottled water. And in this case, the one that is not a risk factor for dental fluorosis would be drinking bottled water. And we'll go ahead and talk about this as well as the other answer choices. So bottled water is kind of a tricky one, and you might not have thought that right away because a lot of people might be aware that when we think of drinking water, we think of fluoride in our drinking water. But this only applies to tap water, not bottled water. So water fluoridation was this great really effective program that the government put out years and years ago in a lot of cities, and it had this big impact on decreasing the caries incidence, but this effect was for like tap water, water that you would get like running through the pipes of your house. This doesn't extend to bottled water. So bottled water does not have that water fluoridation that we get in tap water. Now there is some chance that some bottled water can have fluoride in it, but it would be such a small amount and it's not considered to be a risk factor for fluorosis. Now let's talk about the other answer choices, and we'll start with fluoride toothpaste. Now, fluoride toothpaste can cause fluorosis if given at a young age, especially if the child is really young and doesn't really know how to use toothpaste and is like ingesting it. When you're ingesting this, it causes more of an effect. So when we have toothpaste with fluoride in it, it's recommended that a child under 3 uses a rice grain amount of toothpaste, and then children age 3 to 6 use a pea-sized amount. So we don't want to give them any more of this. So if they're using a whole, like if they're allowed to put their own amount of toothpaste on their toothbrush, it should be monitored. If they put a whole bunch and they're brushing and they're ingesting it, then they could be at risk of fluorosis while their teeth are still calcifying and developing. Now, fluoride supplements, kind of like I just said with the fluoride toothpaste, there is more concern for fluorosis if the fluoride is getting ingested rather than just being applied topically. So when you're getting a supplement, that's something that you ingest, so there is an even higher risk of fluorosis compared to the toothpaste. Now, we're most concerned about ingestion of this fluoride around ages 10 months to 6 years old, because that's when your permanent teeth are calcifying. We generally say that children are okay to receive fluoride between 8 and 10 years old, and we don't really give these fluoride supplements that much anymore anyways. Now, lastly, infant formulas is something that you probably wouldn't think about and something that we don't really learn that much about. Now, infant formulas by themselves can have small amounts of fluoride, but they're not typically a concern. But the risk comes in when you have infant formulas that come in a powder like state and you have to mix water with them to be able to feed them to the baby. And a lot of people, what they would do is they'll mix tap water with this formula, and that tap water has that water fluoridation we were talking about. So if all the baby eats is this powder formula mixed with tap water, and it's always mixed with that fluoridated tap water, then fluorosis can definitely occur. And because of this, the CDC recommends to use low fluoride bottled water at least some of the time to mix infant formula. So even if you can't do it all of the time, they recommend using sometimes to use bottled water that doesn't have fluoride in it. So you'd use like distilled water, deionized water, purified water, something like that when mixing powder baby formula so that the formula, it doesn't have a bunch of fluoride in it. So a lot of things are a risk for dental fluorosis when we have this fluoride toothpaste, these fluoride supplements, these infant formulas, but drinking bottled water is not currently considered a risk for dental fluorosis. This question is asking which is the most common cause of erysipelas, E. coli, Helicobacter pylori, group A streptococcal bacteria, or Staphylococcus aureus. Now, this is a very straightforward question and could get you some easy, quick points on the boards as long as you know it. So let's begin by talking about erysipelas as a whole. Now, erysipelas is an acute bacterial infection that is a form of cellulitis, and it primarily affects the superficial layers of the skin. Common triggers for this infection include trauma to the skin, such as a cut or bug bite, chronic skin conditions such as eczema, poor circulation, an immunocompromised state, or infections in other parts of the body. Symptoms of this infection include redness and swelling of the infected area, which you can see in this image, as well as pain, warmth, tenderness, and possibly even systemic symptoms like fever, chills, and malaise. The most commonly affected areas of the body are the face, legs, and arms, but it can occur anywhere on the body. Treatment for this condition includes antibiotics and supportive care for the pain and swelling, and it usually has a pretty good prognosis. If it becomes severe enough, the complications can include abscess formation, sepsis, and scarring of the skin, and the condition also can reoccur if an individual is at a higher risk. But what causes this specific bacterial infection? It is usually caused by C, group A streptococcal bacteria, a gram-positive bacteria. While other types of bacteria can cause this infection, group A strep is the most common offender. This bacteria is also known to cause other conditions such as strep throat, scarlet fever, and necrotizing fasciitis. Now, although the other bacteria are not the most common cause of erysipelas, let's still talk about each one and talk about what conditions they do cause. We'll start with E. coli, and I'm sure you've definitely learned about E. coli before, as it is a gram-negative bacteria that is naturally found in our intestines. Thankfully, most strains are harmless and aid with digestion, but some can cause infections if they spread to other areas of the body, such as the bloodstream or urinary tract. E. coli is associated with infections such as urinary tract infections. It's actually the most common cause of a urinary tract infection. It can also cause gastrointestinal infections, such as when you get food poisoning, and it can cause sepsis as well. Now, this bacteria is not typically associated with skin infections, such as erysipelas, because it is located in the gastrointestinal system, so we knew that this answer choice was incorrect. Next, we have Helicobacter pylori. Now, this is a gram-negative bacteria that primarily affects the stomach and is well known for its role in causing peptic ulcers and gastritis, and is also associated with an increased risk for gastric cancer. This bacteria is the leading cause of ulcers in the stomach and upper part of the small intestine, and it's also known to cause chronic inflammation of the stomach lining, leading to stomach pain, nausea, and vomiting. A long-term infection with this bacteria is also known to increase the risk of developing stomach cancer. There was also this really famous experiment where the guy who was studying this just decided to swallow it to see what the causes are, so it's definitely known to cause stomach problems. Now, because this bacteria is also primarily involved in gastrointestinal issues and not skin infections, we know that this answer choice was incorrect. And finally, we have Staphylococcus aureus. Now, this may have been a tricky answer choice as this bacteria actually can cause erysipelas, but it's nowhere near as common as group A strep. This bacteria is also a gram-positive bacteria that is commonly found on the skin and mucous membranes. And although it can be part of the normal bacteria flora in healthy individuals, it can cause an infection if it enters the body. Staphylococcus aureus is known to cause infections such as impetigo, cellulitis, abscesses, and osteomyelitis. And like I said, although this can technically cause erysipelas, this bacteria is more commonly associated with deeper tissue infections, and it is not a common cause of this infection, making this answer choice incorrect. So when talking about erysipelas, it's important to know that it is most commonly caused by group A streptococcal bacteria, and not E. coli, not Helicobacter pylori, and not Staphylococcus aureus. This question is asking each of the following factors helps in estimating genetic control except one. Which one is the exception? Mapping and identifying genes, heritability, eugenics, or twin studies. Now this is a very interesting question and one that could be pretty straightforward if you understand what all of these terms mean. We're wanting to estimate genetic control. This means that we basically want to assess how much of the variation in a particular characteristic or trait within a population is influenced by genetic factors as opposed to environmental factors. So we're looking at a characteristic or a trait such as height, and there's different variation in this, and we want to know if that variation is more due to genes, genetic factors, or environmental factors. Now, this is often practically done to determine if a disease is consistently presenting in a family, helping to identify the genetic variant causing that condition. And this can be done in a variety of ways, including family studies, twin studies, adoption studies, gene mapping and identification, often done through something called quantitative trait locus mapping, examining population genetics, and through heritability. And we'll talk more in depth about some of those as we go through the answer choices. But based off of what we just mentioned, we know that the incorrect answer choice would be C, eugenics. Now, this is because eugenics has nothing to do with estimating genetic control, and it's actually more of a scientific and social movement than a test or practice. This movement or set of beliefs aims to improve the genetic quality of the human population through selective breeding for desirable traits. And it really is as bad as it sounds. Unfortunately, this set of beliefs has often been associated with unethical practices, including racism and ableism, and therefore has been majorly discredited. Because eugenics is a set of beliefs and not a factor that helps in estimating genetic control, we know this answer choice is incorrect. Next, we have mapping and identifying genes. Now, mapping and identifying genes is definitely used to estimate genetic control, and it involves locating specific genes associated with specific traits and determining their contributions to the variations observed in those traits. Now, mapping is done through a variety of techniques and involves making a map of the human genome to identify the positioning of genes and their relation to one another. And once these genes have been mapped, identification can be done via sequencing and functional studies, allowing for gene interactions and influences to be assessed. And because this is definitely a factor that helps in estimating genetic control, we know that this answer choice is incorrect. Next, we have heritability. Now, heritability is often one of the first factors used to estimate genetic control, and it involves measuring the proportion of variation in a trait that can be attributed to genetic factors within a specific population in comparison to the environmental factors. In other words, this directly measures the genetic control of a phenotypic trait, and it's expressed as a value between 0 and 1. So a heritability of 0 would indicate that the trait variation is completely due to environmental factors, while a heritability of 1 would indicate that the trait variation is completely due to genetic factors. And because, as we can tell, this is definitely a factor that helps in estimating genetic control, we know that this answer choice is incorrect. And finally, we have twin studies, which is exactly what they sound like, comparing traits in identical twins with traits in fraternal twins. If a greater similarity in traits is seen in the identical twins in comparison to those fraternal twins, it would suggest a stronger genetic component and vice versa. Examples of traits that have been used in these studies include height, BMI, mental health conditions, substance use and addiction, as well as intelligence and medical conditions. And because these types of studies are definitely a factor that help in estimating genetic control, we know that this answer choice is incorrect. So we know that when discussing genetic control, some factors used to estimate genetic control include mapping and identifying genes, heritability, and twin studies, but they definitely do not include eugenics, which is just a set of beliefs. We have a 65-year-old male, and he says, I have had this painful sore in my mouth for 3 weeks, and it isn't going away. We see that he's a tobacco user, he has type 2 diabetes, he's taking metformin, we're given his vitals, and we see this red/white ulcerated lesion on the left side of the tongue that cannot be wiped off, and we're given an image of this lesion as well. And we're asked what is most likely causing that chief complaint. Now, we're given a lot of great information here, and honestly, I'm going to highlight some things that are important. But almost all the information, including the picture that we're given, is important when we're making this diagnosis. So first off, the whole description, the fact that it's a red and white ulcerated lesion, the color really helps us narrow it down, but also the location, the fact that it's on the lateral side of the tongue is important, and the fact that it can't be wiped off. We're going to need all that information put together to make our diagnosis. And the fact that it's been there for 3 weeks and isn't going away. That's a pretty long amount of time when we're not seeing a lesion disappearing if we think it is due to something that would cause it to disappear. So that's another important detail. And finally, the fact that he is a tobacco user. He could be a smoker, that's likely what he is, but that's another important detail in his social history that will help us make the diagnosis. And in this case, based on all that information and based off this picture, we're unfortunately likely seeing a malignancy. Now, what we're likely seeing in this case is oral squamous cell carcinoma, which is actually the most common oral malignancy. This malignancy arises from the surface epithelium, and it can develop from any grade of dysplasia seen. And this would be leukoplakia, erythroleukoplakia, and erythroplakia. And those terms kind of just describe the mucosal changes we see in a lesion like this over time. So the lesion presents initially as an asymptomatic white patch, which thickens and develops into red patches that continue to spread. That's why we're seeing that red and white ulcerated lesion. The white patch that cannot be wiped off represents the leukoplakia part, which is more of a descriptive term. Leukoplakia is not a diagnosis, because here we would biopsy this and the diagnosis would likely be that oral squamous cell carcinoma. So leukoplakia is like a descriptive term. And as the lesion continues to progress, it becomes an erythroleukoplakia, so it starts white, and then it becomes erythroleukoplakia, which means like red and white, and then as it continues to progress more and more, it would just become an erythroplakia. So you go from white to red and white to just red, and erythroplakia is usually the most severe. But like I said, those are different levels of dysplasia we see in surface epithelium, but oral squamous cell carcinoma can develop from any of these premalignant stages. So it could come from leukoplakia, it could come from erythroplakia. It doesn't necessarily matter, even though they typically get more severe as time goes on. Now, clinically, we see these painful sores, persistence of the lesion with ulceration, swelling, numbness, difficulty swallowing. So we're given information like that where we see that it's ulcerated, it's persisting for these 3 weeks, so these are important details. And the fact that we see this on the lateral tongue. This is one of the most common sites for any oral malignancy, but especially oral squamous cell carcinoma. And when you see a lesion on the lateral portion of someone's tongue, that's kind of a red flag. We see that's kind of a warning sign of a location where we would find a lesion. So that's important to know. This is like a danger site. Now, risk factors for oral squamous cell carcinoma include tobacco usage. That's why I also highlighted that fact. That is one of the biggest, if not the biggest, risk factor for oral squamous cell carcinoma, and more than 80% of patients with dysplastic changes like leukoplakia are smokers. This is also more common in males over 50, and we saw that he was a 65-year-old male, so that's another important detail. But a definitive diagnosis would need to be made by a biopsy. So like I said, this is definitely a malignancy, most likely oral squamous cell carcinoma, but doing a biopsy would allow us to kind of finalize that detail. Now let's go ahead and talk about these other answer choices, and we'll kind of see what an example of each would look like. So we'll start with trauma, and I've attached a picture of what a traumatic ulcer would look like. So how would we know that's not what we're seeing in this case? Well, first of all, this would likely go away or at least improve or change after 3 weeks. So that's why that amount of time was kind of important. In 3 weeks, this would probably go away or at least start to improve as long as the area doesn't keep getting re-traumatized. The patient will also likely remember, biting their tongue or some kind of traumatic incident occurring to cause this lesion to happen. And traumatic ulcers, like we see, they present kind of different. They're removable, not that non-removable, can't be wiped off. They're yellowish, white, fibropurulent membrane, and they have that erythema and hyperkeratotic border. So these present a little bit differently than what we were seeing for the malignancy. Now, viral, there are a lot of viral infections that can appear on the lateral tongue and cause painful sores, and particularly, I've attached a picture of what primary herpes infection would look like, but a lot of things can cause this, and they usually present differently, but they also usually have additional symptoms. So 3 weeks, first of all, is a long time to have this viral presentation of the symptoms with no other changes or no other symptoms manifesting, and he doesn't say anything about feeling sick or having any other symptoms. So for example, I said this is primary herpes. We see these shallow ulcers, and they can be on the lateral tongue, but you would also probably see a fever or cervical lymphadenopathy, which is where your lymph nodes swell up. Another example would be oral hairy leukoplakia, which can, that is a form of leukoplakia, and it's usually on the lateral tongue. This is caused by the Epstein-Barr virus, and we see removable white plaques on the lateral tongue, but like I said, you would see other symptoms, especially because this is usually seen in patients who are immunocompromised, like HIV patients, and he is not an HIV patient. So we can see viral lesions in this spot, but that's not what we're seeing, and we're not given any information to think that this is what that was. Now, finally, we'll talk about stress, and I've attached another picture of what we see as aphthous ulcers. Now, stress can definitely cause certain conditions and things to flare up in the mouth, but we have no evidence that he is experiencing high stress levels. When stress is a contributing factor to the question, they'll tell you he just got a recent promotion or something like that would lead you to believe he's under a lot of stress. Now, a stress-induced lesion would also fluctuate with stress levels, and we've had this persistent painful sore for 3 weeks. So he might have a really stressful week, and then it kind of dies down, and this lesion would change over time. It wouldn't last those 3 weeks usually, unless he has a really stressful 3 weeks. And like I said, an example of a lesion that flares with stress are these aphthous ulcers, which I've attached a picture of. And these can be seen on the lateral tongue, but they also present a little bit differently from his lesion. They're also that yellow-white round ulceration with that removable fibropurulent membrane and erythematous halo. They're more similar to a traumatic ulcer. Honestly, those are kind of hard for people to tell apart, but they are different. But neither of them are what we're seeing in the case for this patient. And these can also have like a burning or an itching sensation, but maybe not that painful sore that he was experiencing. So when we have this patient who has this red or white ulcerated lesion on the lateral tongue, a danger site that can't be wiped off. We've had it for a long amount of time. 3 weeks is a long time. When patients come in, we usually give them 2 weeks to see if we see any change in a lesion. So 3 weeks is a long time. We know he's a smoker, and we know he's a male over 50. We can definitely probably assume that this is unfortunately a malignancy, but we always want to do a biopsy to confirm for sure if this was oral squamous cell carcinoma. This question is asking each of the following is a complication of Sjogren's syndrome except one. Which one is the exception? Anemia, joint pain, lymphoma, or decreased erythrocyte sedimentation rate. Now, Sjogren's syndrome is a very important condition to know about because it does have so many oral complications and symptoms associated with it. Now, before we talk about which is not a complication of this syndrome, let's talk more about Sjogren's syndrome as a whole. Now, this is an autoimmune condition that attacks the lacrimal and salivary glands, causing xerostomia and dry eyes. It may also be seen in conjunction with other autoimmune diseases such as lupus or Hashimoto's thyroiditis. This condition typically affects middle-aged to older adults and has a very strong female predilection. Patients often complain of a dry, gritty feeling in the eyes and a dry mouth, and swelling of the parotid is often seen as well. Other oral findings that typically come alongside this diagnosis include cervical caries, increased candidiasis prevalence, and burning feeling of the tongue. Diagnosing this condition can be difficult as there are specific international classification criteria for Sjogren's syndrome. Treatment for this condition includes hydration, artificial tears and saliva, and medications that induce salivation. Now, we've talked about the common symptoms and oral findings seen in this condition, but let's talk more about the systemic complications that can also be seen. This condition presents so differently among patients, but common systemic complications include fatigue, joint pain and arthritis, kidney problems, liver disease, anemias, inflammation of blood vessels, peripheral neuropathy, increased risk of developing non-Hodgkin lymphoma, thyroid dysfunction, and increased risk of infections. But a complication we would not see is D, a decreased erythrocyte sedimentation rate. And this is because this rate is actually increased in patients with this condition. Now, the erythrocyte sedimentation rate, or ESR, is a blood test that measures how quickly red blood cells, which are also known as erythrocytes, settle to the bottom of a test tube in a given period of time. It's used as a nonspecific marker of inflammation in the body because the test indirectly measures the level of inflammation by assessing how the red blood cells aggregate and form a sediment in the blood. Now, if a patient had a decreased ESR, then they likely have a high red blood cell count or extreme dehydration that is slowing that rate of sedimentation. If they have an increased ESR, which is more common, they likely have some form of inflammation, infection, or autoimmune disease, which is why we would see an increased erythrocyte sedimentation rate in patients with Sjogren's syndrome. Now, even if you were unfamiliar with the erythrocyte sedimentation rate, you could have gotten this question right just by knowing that anemia, joint pain, and lymphoma all are, in fact, complications seen in this condition. Now, let's quickly go over those complications. And we'll start with anemia. Now, a number of different types of anemia are actually associated with Sjogren's syndrome, but this is typically more of a mild complication. It often arises due to chronic inflammation affecting red blood cell regulation and can present as autoimmune hemolytic anemia, anemia of chronic disease, iron deficiency anemia, or a number of other anemic presentations. But because this is certainly a complication, even a mild one, that can be seen with this autoimmune condition, we knew that this answer choice was incorrect. Next, we have joint pain. Now, this is another common complication of Sjogren's syndrome. The joint pain seen is typically classified as non-erosive arthritis, meaning it can cause significant discomfort and functional impairment, but it does not actually cause joint damage or deformities. This type of arthritis can result in pain, swelling, and stiffness, especially in the morning, and it's usually due to autoimmune inflammation, that same inflammation that is causing an increased erythrocyte sedimentation rate, so it all ties in together. Now, because Sjogren's syndrome is often seen in conjunction with other autoimmune conditions, the joint pain may even be due to a patient experiencing rheumatoid arthritis symptoms at the same time. But because this is certainly a complication that can be seen with Sjogren's syndrome, we knew that this answer choice was incorrect. And finally, we have lymphoma. Now, this syndrome's association with B-cell lymphoma is one of the most serious complications of the disease, and it's typically associated with long-standing inflammation once again. Patients with Sjogren's syndrome actually have a 44 times increase in lymphoma when compared to an age and sex-matched population, and a 15 to 20 times greater risk when just compared to the general population. Now, this is due to chronic activation of the immune system, particularly B-cell hyperactivity and lymphoid tissue formation in the glands. This prolonged inflammation and immune dysregulation, combined with genetic predisposition and possible infections, increase the risk of malignant transformation of these lymphoid tissues. So because this is unfortunately a complication seen in patients with this syndrome, we knew that this answer choice was incorrect. So when talking about Sjogren's syndrome, complications include anemia, joint pain, and lymphoma, but do not include a decreased erythrocyte sedimentation rate. The erythrocyte sedimentation rate would actually be increased in patients with this condition due to elevated levels of immunoglobulins and all of that inflammation present. We have a male, he's 43 years old, and he's here for his routine checkup. He has anxiety, depression, oropharyngeal squamous cell carcinoma. He's taking some medications, he has gingivitis, recession of the buccal marginal gingiva on his maxillary right and left first molars. And we're asked, which human papillomavirus, or HPV, is commonly associated with HPV-positive oropharyngeal squamous cell carcinoma? Now, this is an important question as there are many types of human papillomavirus, and we should know which strains are cancerous or high risk for cancer and which are not. Let's start first by just talking about HPV as a whole. Now, HPV is a group of more than 200 related viruses, and it also happens to be the most common sexually transmitted infection in the US. Some types are sexually transmitted while others are not, and some types, like we said, are high risk for cancer while others are low risk. HPV enters the epithelial cells of the mucosa and skin, and it infects the basal cells. Now, although most HPV infections are asymptomatic and will resolve spontaneously, some infected cells remain latent for decades. These cells have low levels of replication, minimal viral protein expression, they lack immune clearance, and can cause a persistent infection of up to 20 years. High-risk types of HPV can make specific proteins, allowing for the cell to grow uncontrolled and avoid death, as well as allowing it to spread via terminally differentiated keratinocytes. The strains that are high risk for cancer, which are 16 and 18, are the strains associated with oropharyngeal cancer, making D the correct answer choice. But I also want to note that they can be associated with other types of cancer, such as cervical cancer, anal cancer, and vaginal cancer, among others. It's not just that they're associated with oropharyngeal cancer. Now, over 85% of HPV-positive oropharyngeal squamous cell carcinoma cases are caused by those two strains, 16 and 18. Now, the treatment for oropharyngeal cancer depends on how early in the disease process it is caught. Early treatment includes chemoradiotherapy and surgery, while later treatment includes chemotherapy and radiation as well. The prognosis is dependent on the presence of HPV as well as if the patient is a smoker. Patients who have HPV and are non-smokers have the best prognosis, while patients who do not have HPV and smoke have the worst prognosis. So although you would definitely not want to have oropharyngeal squamous cell carcinoma at all, you do have a better prognosis if it's due to HPV than if it's associated with smoking. Now, although HPV 16 is the only answer choice given that is a high-risk strain for oropharyngeal cancer, let's quickly go through the other strains and discuss what they may cause. We'll start with HPV 6. Now, this strain of HPV is actually incredibly similar to HPV 11, another answer choice, and the two are known to cause the same lesions and have the same characteristics. So as I talk about HPV 6, it's going to be identical for HPV 11. I won't repeat it, but they're basically the same. Now, this strain is not sexually transmitted and is not high risk for cancer, and it's known to cause lesions known as squamous papillomas. Oral squamous papillomas are benign growths seen in patients of any age, and like I said, they're not sexually transmitted like other HPV growths can be. Clinically, they are usually pedunculated but can't be sessile, and they're exophytic, meaning that they grow outward beyond the surface epithelium. They have finger-like projections, and they are usually solitary lesions, and those projections give them this wart-like or cauliflower appearance that they're known for. They're soft and painless, and their color can vary between the shade of the surrounding tissue or more of a white color depending on the amount of keratin present. They're commonly found on the tongue, like you see in this image, uvula, soft palate, and lip, but can be seen in any location. These lesions are removed via conservative excision, but sometimes they can spontaneously go away on their own and not even require any treatment. But because this HPV 6 strain is not a high-risk strain for cancer and is not associated with oropharyngeal cancer, we know this answer choice was incorrect. Next, we have HPV 8. Now, this strain of HPV is not one that we really discuss much as it's not really associated with lesions that we see in the dental world. It's currently believed to be linked to some skin lesions and possibly even be linked to certain skin cancers, but it's not associated with oropharyngeal cancer, so it would be incorrect. And like I said, HPV 11 is basically identical to HPV 6, so I'm not going to repeat everything. These two strains are incredibly similar and they cause the same lesions to form. So they're both not sexually transmitted, they're both low risk for cancer, and they both cause squamous papillomas. So because of this, we know that this strain is not associated with oropharyngeal cancer, and this answer choice is also incorrect. So we know that when discussing HPV strains that are high risk for cancer and are commonly associated with oropharyngeal squamous cell carcinoma, we are talking about HPV strains 16 and 18 and not 6, 8, or 11. We have a 53-year-old female who says every time I swallow, it's painful, and we're given this image to look at as how her condition is presenting. And we're asked, what is the most likely diagnosis? Now, when we see this presentation, it can be kind of alarming if a patient walks into your practice with a swelling in their neck. It's always a priority to make sure that the patient is able to breathe and the airway is not obstructed. In this patient, thankfully, this does not seem to be a concern, but we still want to diagnose this condition so that we can treat it for her. The picture is going to be the most helpful clue in making this diagnosis. We see this swelling in the patient's neck area directly below the mandible, and the swelling appears to be more prominent on her right, meaning it's not a bilateral swelling. It's also important to note that the patient tells us, every time I swallow, it's painful. This is not only a helpful clue because we know there's pain on swallowing, but it's also helpful because it tells us that the lesion is not incredibly painful on its own when she does nothing. If a patient comes in and says, it hurts when I swallow, and it's hurting all the time, they would come in and say, oh my God, I'm in so much pain, it hurts so bad all the time. They wouldn't just say there's pain when they swallow. Now, this helps us eliminate any really acute diagnoses, such as an abscess from a tooth infection that spread down into some dangerous spaces. Based on the location of this swelling and the fact that there is pain from swallowing, we can see that the correct answer choice out of our options would be D, submandibular sialadenitis. Now, sialadenitis is an inflammation of the salivary gland that can be either acute or chronic, with the chronic form being associated with salivary duct damage. This inflammation is typically caused by a bacterial infection, but can also be caused by things like mumps or ductal obstruction. Clinically, this presents with a diffuse unilateral swelling that is painful or tender, especially around mealtimes as someone has an increase in salivary production or when they're swallowing. The gland may feel warm and the overlying skin may be erythematous as well. The acute form of the condition is most commonly seen in the parotid gland, while the chronic form is usually seen in the submandibular gland, which is where we're seeing it here in our patient. Treatment for this includes hydration, pain medications, warm compresses, massaging the gland, broad-spectrum antibiotics, and even surgical gland removal depending on severity. Although this is definitely the correct answer choice for this lesion, let's go ahead and go through the other answer choices and discuss what they are and how they're similar and different from our sialadenitis. We'll start with streptococcal pharyngitis. Now, this is the official name for strep throat, a bacterial infection that is known to cause a sore and scratchy throat, and I'm sure you're familiar with it. This infection is most common in children, but can affect any age, and if untreated, can cause complications that include rheumatic fever. It's spread through droplets or shared food and drink and is treated with antibiotics. Clinical signs of this condition are throat pain, painful swallowing, swollen and red tonsils, headache, fever, nausea, vomiting, body aches, and palatal petechiae, which you can see in this image. How is this similar, though, and how is this different from our sialadenitis? These both can cause painful swallowing and swelling in similar areas. Both can be caused by bacterial infections, but other than that, we would see a unilateral swelling of the submandibular glands in sialadenitis, but in strep throat, we would see bilateral swelling of the lymph nodes. That's the difference. So one would be a swelling in the lymph nodes, and it would be bilateral, and one is a swelling in that actual salivary gland. Now, this is also a more systemic condition. A patient with strep throat would have more than just pain on swallowing. They would have those swollen lymph nodes, a scratchy or sore throat, and likely fever and body aches and all those other symptoms, while sialadenitis typically just presents with pain and warmth of that lesion. And these two lesions would be treated differently, although antibiotics can be used for both conditions sometimes. Next, we have Sjogren's syndrome. Now, this is an autoimmune condition that attacks the lacrimal and salivary glands, causing xerostomia and dry eyes. It may also be seen in conjunction with other autoimmune diseases such as lupus or Hashimoto's thyroiditis. This condition typically affects middle-aged to older adults, and it has a very strong female predilection, like 9-to-1 strong, very strong. Patients often complain of dry, gritty feeling in the eyes and a dry mouth, and swelling of the parotid is often seen as well, which you can see in this patient. Other oral findings that typically come alongside this diagnosis include cervical caries, rampant cervical caries, increased candidiasis prevalence, and burning feeling of the tongue. Now, diagnosing this condition can be difficult as there are specific international classification criteria for Sjogren's syndrome. Treatment for this condition includes hydration, artificial tears and saliva, and medications that induce salivation. You're kind of just treating the symptoms here. Now, how is this different and how is this similar from our sialadenitis? Now, both can cause swelling of a salivary gland, even though they're different glands. So here we see the parotid, but in our condition we saw the submandibular. And they're both salivary gland conditions, but that's really the only similarity. This is an autoimmune condition and not an inflammatory reaction. This syndrome is associated with other symptoms such as dry eyes and dry mouth, which our patient is not exhibiting. And this is not associated with the submandibular swelling or pain on swallowing. This is managed more than it's treated. So sialadenitis we can treat and cure, while Sjogren's syndrome we're kind of just treating the symptoms, and they're managed very differently. Finally, we have acute lymphadenitis. Similar to how sialadenitis just meant inflammation of the salivary glands, this would just be acute inflammation and enlargement of the lymph nodes. This process is usually due to an infection, and it causes the affected lymph node to not only increase in size, but to become palpable and sore. This is typically a localized infection seen only in lymph nodes of one area, but it can be generalized depending on the cause of the infection. The fact that this is acute means that it likely came on pretty quickly and aggressively. Treatment for this involves treating the causative infection, whether it be through antibiotics, antivirals, antifungals. It totally depends on what is causing that infection and that inflammation. How is this similar and how is this different from our submandibular sialadenitis? These are both inflammatory lesions that may be due to a bacterial infection. Both can cause swelling and tenderness in similar areas. How are they different though? Now, this is a lymph node lesion and not a salivary lesion. Although the lymph nodes present in a similar area as the submandibular gland, they're not in the exact same location, and you should be able to palpate the two differently when you're looking for them doing a head and neck exam. Now, typically, lymphadenitis would result in bilateral swelling of the lymph nodes in the neck rather than a unilateral swelling. Although the affected lymph nodes may be sore or tender, they typically would not present with pain on swallowing, such as we saw in sialadenitis. And the two lesions would likely be treated differently depending on the cause of the inflammation. So they have different symptoms and they're in slightly different locations, and one is usually bilateral while the other is usually unilateral. Now, so we know that when you see this patient, she comes in, and it's always something of concern when you have a neck swelling, but when you specifically see a patient with a unilateral swelling that has trouble or pain on swallowing, you should know that submandibular sialadenitis is a likely diagnosis. We have a 58-year-old female who says, I need a cleaning. She has Addison's disease, celiac disease, she's taking some medications, and her blood pressure and heart rate are normal. And we're asked, which is an immunological hallmark of the autoimmune form of Addison's disease? Now, before we talk about the immunological hallmark of any form of Addison's disease, let's first talk about Addison's disease as a whole. Addison's disease is another name for primary chronic adrenocortical insufficiency, and it's characterized by the progressive destruction of the adrenal cortex. This leads to a lack of certain hormones, especially cortisol and aldosterone as well. This also leads to increased serum ACTH, or adrenocorticotropic hormone, because the destruction of the cortex prevents a feedback response to this hormone. Clinical features of this disease often present slowly, and they include progressive weakness, fatigue, GI disturbances such as nausea, vomiting, and diarrhea, a craving for salt, and cutaneous or oral hyperpigmentation, which is what you can see in this image. The symptoms can also present suddenly, and in that case, it's known as acute adrenal failure or an Addisonian crisis. Now, there's no cure for this condition, but treatment includes hormone replacement therapies to correct the level of steroids the body isn't able to make, as well as receiving plenty of salt in the diet. But back to the question. To be able to answer a question about the different forms of Addison's disease, we need to know exactly what causes it in the first place. The primary adrenal insufficiency seen in Addison's disease is a result of damage to the adrenal cortex, like we said, and this is usually the result of an autoimmune disease. It can also be due to tuberculosis, infections of the adrenal glands, cancer in the adrenal glands, and certain medications or cancer treatments. But because the question is focusing on the most common form, the autoimmune form, that is what we'll focus on as well. In autoimmune Addison's disease, the immune system is malfunctioning and is targeting and attacking the adrenal cortex itself. And because we know it is attacking the adrenal cortex in this condition, and because we know that the body attacks itself via autoantibodies, we know the correct answer choice is D, adrenal cortex autoantibodies. So, just to emphasize, even if we didn't know this answer right away when reading the question, we could have still figured it out. We know that Addison's disease involves insufficiency of the adrenal cortex, and we know that when the immune system is making antibodies that target our own body, they're known as autoantibodies. So we would have been able to determine that autoantibodies attacking the adrenal cortex would cause the insufficiency seen in Addison's, making D the correct answer. This is also reinforced by the other three answer choices having nothing to do with Addison's disease. But let's go ahead and talk about them anyways. Now, before going through the other answer choices, I also want to mention that an immunologic hallmark means that adrenal cortex autoantibodies are something that would be seen when testing a person for Addison's disease. And if they had these, it would be an indicator for the condition. So these other answer choices are also immunological hallmarks or test results, but they indicate different conditions. So we'll start with low levels of IgM. And if you don't remember what IgM or immunoglobulin M is, it is an antibody produced by our immune system in response to an antigen. IgM is actually typically the first antibody to appear in response to an antigen, and it's known to provide short-term protection while the body takes time to produce more antigen-specific antibodies. These antibodies are found in the blood and lymph, and low levels of these antibodies can indicate a number of conditions, including a selective IgM deficiency, B-cell cancers like lymphoma, lupus, and even celiac disease. So she could have this because of her celiac disease, but not because of the Addison's disease. Now, IgM has nothing to do with Addison's disease, and because low levels of IgM are not the immunological hallmark for this condition, we know this answer choice was incorrect. Next, we have thyroid gland autoantibodies. Now, the autoantibodies portion of this answer choice was correct because they are autoantibodies, but this is for the wrong organ, so this is incorrect. We are seeing autoantibodies, which is what we want to see, but not for the thyroid gland. Thyroid gland autoantibodies would cause inflammation, tissue damage, and disruption to the function of the thyroid, and are seen in thyroid-specific autoimmune conditions like Hashimoto's thyroiditis or Graves' disease. The thyroid is not affected at all in Addison's disease, and because thyroid gland autoantibodies are not the immunological hallmark for this condition, we know this answer choice was also incorrect. And then finally, we have low circulating lymphocytes. Now, this answer choice may have been a little bit tricky, as the autoantibodies that do attack the adrenal cortex in the autoimmune form of Addison's disease are in fact lymphocytes. So if you knew a lot about this and knew that lymphocytes attack the cortex to cause the damage seen in Addison's disease, you may have been tempted by this answer. But even though lymphocytes do damage the adrenal cortex in Addison's disease, this does not contribute to low circulating lymphocytes at all, and it really has no effect on lymphocytes in the bloodstream. A low circulating number of lymphocytes is also known as lymphopenia, and it can be caused by viral infections like HIV, tuberculosis, blood disease, and malnutrition, among other things. But not seen in Addison's disease. So because low circulating lymphocytes are not the immunological hallmark for Addison's disease, we know this answer choice was also incorrect. So we know that when we're talking about the autoimmune form of Addison's disease, the immunological hallmark would be adrenal cortex autoantibodies. The body is attacking itself in the form of autoantibodies, and the affected organ in Addison's is the adrenal cortex, so we know that this is the right answer choice. We have a 45-year-old female who's here for a checkup. She's a new immigrant from Africa, and we notice apical radiolucencies at the apex of all mandibular incisors with well-defined periphery. They're asymptomatic, and vitality testing of the mandibular incisors show that they're all positive. They're all vital teeth. And we're asked, what's the most likely diagnosis? Now, we're given a ton of information here, and actually a lot of it we will be used to make this diagnosis. And we'll start with the fact that we have these apical radiolucencies at the apex of all mandibular incisors. This should hint to us that since we're seeing it on all the incisors, that this may be a condition that's more generalized. It's not just localized or singular to one tooth, so that's a big clue. Also, this vitality testing is another huge clue. This is a super important piece of information because some radiographic lesions are always associated with a non-vital tooth, so that would eliminate them as answer choices as a possible diagnosis. So knowing that the teeth are vital is a huge clue. And then finally, the fact that she's an immigrant from Africa is actually another huge clue because the correct diagnosis in this case is actually most common in middle-aged African women. So we're kind of given a big hint there. And what we're seeing in this condition is periapical cemento-osseous dysplasia. Now, periapical cemento-osseous dysplasia is a subset under cemento-osseous dysplasia. So it's cemento-osseous dysplasia, and then periapical is a subset of that. And this is an acquired fibrous osseous lesion. So this is a benign, possibly reactive process that originates from fibroblasts of the PDL. And this is the most common fibroosseous lesion encountered in clinical dentistry and is most common in Black females, like we said. This condition affects the tooth-bearing areas of the jaws, is asymptomatic, and the teeth involved are always vital. Huge clue, like I said. Radiographically, this ranges from completely radiolucent to densely opaque with a thin radiolucent rim, but the PDL will always remain intact. Now, the spectrum of severity for cemento-osseous dysplasia starts with periapical COD, which is mild, focal COD, which is moderate, and then florid COD, which is severe. So our patient has periapical COD, which is the mild form, and it's usually seen in the mandibular anterior region, but it can be seen in the maxillary interior as well. Obviously, we're seeing it for our patient in the mandibular anterior region, which is where it's most common. Now, this initially presents as unilocular radiolucencies at the apices of the mandibular incisors, and a central opacity will start to develop over time. And like I said, this is exactly what the patient box is describing. We're getting these apical radiolucencies in their exact location, the teeth are vital, and the demographics of the patient fit perfectly. So we're definitely seeing periapical cemento-osseous dysplasia, definitely our diagnosis here. All of the information fits, but let's go through the other answer choices, talk about what they are, how they're similar, and how we know they're not the diagnosis. Now we'll start with a radicular cyst. Now this is also known as a periapical cyst and is the most common cyst of the jaws. These are believed to be due to inflammatory stimulation of the epithelial rests that are found in the PDL. This is asymptomatic and is always associated with non-vital teeth. Huge clue there. This is always associated with non-vital teeth. We can eliminate this answer choice automatically based off the vitality testing of our patient's teeth. Now, radiographically, this is a round to ovoid radiolucency at the apex of a tooth, and a loss of lamina dura is seen. How is this similar and how is this different from our diagnosis? Now, both lesions are radiolucent, located at the apex of teeth, and both are due to something in the PDL. But they're different in that these are always associated with non-vital teeth, while periapical cemento-osseous dysplasia is always associated with vital teeth. Very important difference. This is also usually a singular lesion seen on one tooth, and it's not a generalized condition like periapical COD. A radiopacity also does not begin to form over time for this lesion, and we saw that that did happen with our diagnosis, and this also has no important demographic correlations. Next is a peripheral giant cell granuloma. This is totally off from our diagnosis. This is a benign fibrous mesenchymal tumor that is reactive, meaning it's caused by local irritation or trauma. Clinically, this is painless, dusky purple-red, and is only found on the gingiva of the alveolar ridge. So we're not even seeing this as a bony lesion. It can, radiographically, if the lesion is really large, it can cause cupping of the underlying bone, but it's not a bony lesion. Now, these are similar in that they both would be asymptomatic, and technically the teeth around both lesions would remain vital. This isn't really affecting the vitality of the teeth, so it wouldn't cause non-vital teeth, so they're similar in that way. And both are actually might be reactive processes. This is definitely reactive, and it's thought that periapical cemento-osseous dysplasia is also reactive. But these two conditions are different in a lot of ways. This is a soft tissue lesion, and it usually has no osseous effects. This is located on the gingiva, and it's not a radiographic lesion that we see at the apices of teeth. This has nothing to do with the PDL, and it has no correlation with any demographics. So it's very different here. And finally, periapical granuloma, this actually presents identical to a radicular cyst, and they can't be differentiated clinically or radiographically. So they're basically the same when you're looking at them. The only way you know the difference is if you did a biopsy. So the two lesions are practically the same. The only difference is that a periapical granuloma has no cyst lining and is characterized by inflamed granulation tissue surrounded by fibrous tissue. So the lesion in this picture could have been either a radicular cyst or periapical granuloma, but it was determined to be a granuloma histopathologically. So it's the only reason we even know that that's what this is. So the similarities and differences compared to periapical cemento-osseous dysplasia would be exactly the same for radicular cysts. So both are radiolucent lesions located at the apices of teeth. Both are due to something in the PDL. These are always, once again, still associated with non-vital teeth, while periapical cemento-osseous dysplasia is always associated with vital teeth. Same differences, same similarities. This is a singular lesion seen on one tooth. It's not a generalized condition, and a radiopacity does not begin to form, and this has no important demographic correlation. So this has all the same things as a radicular cyst. The only difference is it doesn't have that cyst lining. So they're very similar, and both are not like periapical cemento-osseous dysplasia. So when we have this patient and she's an immigrant from Africa, that's a helpful clue. She's middle-aged, she's Black, she's female, and the fact that we have these radiolucencies at the apices of all these mandibular incisors, it's generalized, the teeth are still vital, it's asymptomatic. What we're definitely seeing here is periapical cemento-osseous dysplasia.
This question asks, which is the most likely diagnosis? So let's take a look at our answer choices. First we have glioblastoma. This would present as a multilocular radiolucency with a soap bubble appearance. This is also very aggressive and would present with expansion. This is not what we're seeing in the radiograph or the clinical presentation, so we can eliminate this answer. Next, we have condensing osteitis. This would be a uniform radiodensity adjacent to the apex of an inflamed tooth. Now, while the patient is having mild pain in the lower anterior teeth, there's no mention of lack of vitality or pulpitis on these teeth. Additionally, this is not a uniform radiodensity we're seeing here in these periapical images. We're seeing mixed radiolucent and radiopaque forms, so we can eliminate this answer as well. Next, we have a cementoblastoma. This would be a round mixed density lesion surrounding the apex with a radiolucent periphery. This is also not what we're seeing here, as this is more of a scattering of radiopacities and radiolucencies, so this is not consistent. Finally, we have a cemento-osseous dysplasia. This would present with early radiolucencies. Later on, we would see mixed radiopaque and radiolucencies. And finally, we would see a lot of radiopacities. And this is because this is the process of bone being replaced with fibrous tissue. This is consistent with the radiograph. So option D is the correct answer to this question.
This question is asking each of the following is a component of the Stop Bang questionnaire for obstructive sleep apnea except one. Which one is the exception? Tiredness, body mass index over 35 kilograms per meter squared, female gender, or high blood pressure. Now, the Stop Bang questionnaire for obstructive sleep apnea may be a questionnaire that you've already used to screen patients for, or it may be one that you choose to use in the future. But either way, this is a very important questionnaire to know about. And as long as you're familiar with the questionnaire, this could be some quick, easy points for you on the board exam. Now, before we dive into all of the components of the questionnaire, let's start by talking about obstructive sleep apnea as a whole and why you'd need a questionnaire like this in the first place. Now, if we just break down the name, apnea refers to the temporary cessation of breathing, and because it is sleep apnea, this is obviously occurring while the patient is asleep. Obstructive just refers to a blockage, so in this condition, this breathing cessation is due to some kind of obstruction or blockage. There are a number of risk factors associated with this condition that you've probably heard of or even screened patients for yourself. Enlarged tonsils or tongue, obesity as the excess weight can contribute to that airway obstruction, being male, being over 40, and a number of medical conditions such as hypertension and type 2 diabetes. Social habits such as smoking and excessive alcohol use are also risks. The most characteristic symptoms of the condition are loud snoring, choking or gasping during sleep, excessive daytime sleepiness due to that lack of deep sleep, difficulty concentrating, morning headaches, irritability, nighttime sweating, and waking up with a dry mouth or sore throat. To officially diagnose this condition, a sleep study is often done to measure breathing patterns and oxygen levels while a patient sleeps. Treatment for this condition varies based on severity, but often includes lifestyle changes like weight loss and avoiding alcohol, as well as a CPAP machine and even surgery if severe enough. As far as screening or assessing for this condition, the ADA has actually put out a full statement explaining our roles as dentists in screening patients for this condition. And there are a number of validated questionnaires available to start this process. Some of the most widely used risk assessment questionnaires are this Stop-Bang questionnaire, the Berlin questionnaire, the Epworth Sleepiness Scale, the Sleep Apnea Clinical Score, the OSA 50, and the Snore Score. But let's specifically obviously talk about the Stop-Bang questionnaire, as that's what this question is focusing on. Now, this is one of the most widely used and validated screening tools for obstructive sleep apnea. Stop-Bang is an acronym, and this questionnaire assesses 8 risk factors for obstructive sleep apnea. S for snoring, T for tiredness, especially daytime tiredness, O for observed apnea, P for pressure, which is referring to hypertension or high blood pressure, B for BMI above 35, A for age being greater than 50, N for neck circumference being greater than 40 centimeters, and G for gender being male. Patients will answer yes or no to each question, and based on the number of yes responses, they are assigned a score, with a higher score indicating a higher risk of obstructive sleep apnea. 0 to 2 yeses suggests a low risk, 3 to 4 suggests a moderate risk, and 5 to 8 suggests a high risk. If a patient scores high on this questionnaire, they're often advised to undergo further evaluation, which may include those sleep study tests we discussed earlier. Now, based off of everything we just said about this questionnaire, we know that the correct answer choice, or the answer choice that is not a component of the questionnaire, is C, female gender. Gender itself is definitely something that is being examined in this questionnaire, as that is what the last letter in BANG stands for. But because the risk for obstructive sleep apnea increases if a patient is male and not female, male gender would be a component of the questionnaire and not female gender, making this answer choice incorrect. Now, men typically have larger and thicker necks and are also more likely to accumulate fatty tissue around the neck and throat area. Other potential reasons include the fact that testosterone may contribute to muscle relaxation in the throat, while estrogen has more protective effects on the upper airway muscles. Men are also more likely to seek medical attention for sleep apnea-related symptoms, such as snoring and daytime sleepiness, so they often have a higher rate of diagnosis. Women tend to have more subtle symptoms, and they're more likely to be underdiagnosed or misdiagnosed. By default, and from talking about earlier, we already know that all of the other answer choices are components of the questionnaire, but let's briefly review them anyways. We'll start with tiredness. Now, this tiredness, fatigue, or excessive daytime sleepiness is definitely an important component of the questionnaire, and it represents the T in STOP. The patient is specifically asked if they often feel tired, fatigued, or sleepy during the daytime, as this is a very common presentation of obstructive sleep apnea. If a person is unable to breathe while they sleep and they're constantly gasping and choking, then they really aren't getting any good deep sleep. So the combination of frequent arousals, the lack of deep sleep, and oxygen deprivation all contribute to the daytime sleepiness experienced by these patients. So because this is definitely part of that questionnaire, we knew that this answer choice was incorrect. Next, we have body mass index over 35 kilograms per meter squared. Now, this body mass index, or BMI, represents the B in the bang portion of the questionnaire and is looking to assess if the patient is obese, as a BMI of over 30 is considered obese. And like I said earlier, this is because the excess weight can contribute to airway obstruction. So because this is definitely part of the questionnaire, we knew that this answer choice was also incorrect. And finally, we have high blood pressure. Now, this one may have been tricky because there's no H in stop bang, but the P in stop refers to pressure, indicating high blood pressure or hypertension as a risk factor for this condition. Now, hypertension and obstructive sleep apnea actually have an interesting relationship, as each is independently a risk factor for the other. But as long as you just know that the two are associated, you'll be okay. So because hypertension or pressure, high blood pressure, is definitely part of the questionnaire, we knew that this answer choice was incorrect. So it's important to know that the stop bang questionnaire for obstructive sleep apnea risk assessment does assess tiredness, body mass index, and high blood pressure as risks, but it does not ask for female gender, as there is a higher risk in males for this condition. This question is asking which statement is correct regarding Gardner's syndrome. It presents with multiple polyps of the large intestine with malignant potential. It's associated with cleft lip and lip pits. There are intestinal polyps that have no propensity to malignant change, or it consists of polyostotic fibrous dysplasia. To answer this question, we just need to know what characteristics of Gardner syndrome are, so let's talk about this condition. This is an uncommon autosomal dominant and highly penetrant syndrome. It's one of several polyposis syndromes, and the most significant aspect is the development of precancerous polyps of the colon. These colorectal polyps develop by the second decade and ultimately transform into adenocarcinomas. The syndrome is also characterized by multiple osteomas, epidermoid cysts, desmoid tumors, and skin fibromas. Gardner syndrome has dental effects as well, which include impacted teeth, the presence of supernumerary teeth, and odontomas. Treatment for this syndrome include a prophylactic colectomy, removal of cosmetically problematic cysts and osteomas, and genetic counseling. The prognosis is unfortunately guarded due to the development of those adenocarcinomas. Now, based off of everything we just said about Gardner syndrome, we should know that the correct answer choice is A, that it presents with multiple polyps of the large intestine with malignant potential. As we said earlier, this is a polyposis syndrome, and these numerous polyps in the larger intestine do have a high likelihood of transforming into adenocarcinomas. We know this is the correct characteristic of Gardner syndrome, but let's still go through all the other answer choices and discuss why they are incorrect and what condition they would be seen in. And we'll start with is associated with cleft lip and lip pits. Cleft lip and lip pits are seen in a condition known as van der Waals syndrome, a genetic mutation that causes cleft lip, cleft palate, pits or indents in the lower lip, possible mounds of tissue in the lips, and possible hypodontia. Patients with this syndrome receive the same treatment as any other cleft lip and palate patient, and the lip pits or mounds can be removed with a minor surgical procedure, making the prognosis for this syndrome very positive. This answer choice was incorrect because Gardner syndrome is not associated with cleft lip or lip pits at all. Next, we have intestinal polyps that have no propensity for malignant change. Now, this answer choice was definitely the tricky one, as it also mentions intestinal polyps. So it was really important that you remembered the most significant aspect of Gardner syndrome is the fact that the polyps are precancerous. The condition that is characterized by non-cancerous intestinal polyps is known as Peutz-Jeghers syndrome. This is a rare developmental condition usually noted in childhood. It's usually an autosomal dominant inherited mutation, and it's due to a mutation in the STK11 gene, allowing for uncontrolled cell growth. Clinically, it presents with benign polyps of the gastrointestinal tract, and it can also cause bowel obstruction due to intussusception, which is just telescoping of the proximal segment of the bowels into the distal segment, so it kind of telescopes in there. Now, these polyps unfortunately lead to patients with this syndrome having an 18 times higher risk of developing cancer, but I want to stress that these actual polyps are not precancerous themselves. They're just getting so much growth, so much uncontrolled cell growth that they are at more risk for cancer, but the actual polyps are not precancerous themselves like they were in Gardner syndrome. Now, oral manifestations of the condition include hyperpigmented brown or black macules of the lips and oral mucosa, and you can see that in this image. They also may fade with age. Treatment for this includes genetic counseling for the parents and patient, and to monitor for that intussusception and tumor development. But because the intestinal polyps in Gardner syndrome do have a propensity for malignant change, this answer choice was incorrect. And finally, we have consists of polyostotic fibrous dysplasia. Fibrous dysplasia occurs when fibrous tissue replaces sound, healthy bone, and polyostotic fibrous dysplasia means that this is occurring in multiple bones. Fibrous dysplasia on its own, as an acquired bone disorder, is usually monoostotic or only affecting one bone, but when it's part of McCune-Albright syndrome, it is polyostotic in nature. In this syndrome, two or more bones are affected by fibrous dysplasia. That's why it's polyostotic, two or more bones. Cafe au lait cutaneous lesions are present, and the patient undergoes precocious or early puberty. This condition is due to a genetic mutation and is treated via medications to strengthen bones and manage hormones. And you can see those cafe au lait lesions, those spots, on the patients in the left. So that's what those skin lesions are. They kind of look like coffee stains, so that's why they're called that. Now, we knew that this answer choice was incorrect because polyostotic fibrous dysplasia, or any kind of fibrous dysplasia, is just not a characteristic that is associated with Gardner syndrome. So we know that when discussing Gardner syndrome, the condition presents with multiple polyps of the large intestine, and they do have malignant potential. That's very important to remember. These will transform into adenocarcinomas, and it's important to keep track of that. We have a 38-year-old male who says, I have painful ulcers all over my mouth. He has hypertension, painful recurrent oral and genital ulcers. He's taking medications, his blood pressure is normal, and we notice these 0.5 centimeter shallow, small, white ulcers at the soft palate, gingiva, buccal and labial mucosa, some in clusters and some single. He also has small lesions noted on the right forearm and neck, and if we look at this image, we can see how that oral lesions, how they're presenting. And we're asked, what is the most likely diagnosis? Now, we're given some really helpful indicators to be able to diagnose what condition this patient has. The major clue that we need is the fact that this patient has painful recurrent oral and genital ulcers. Honestly, just this statement is enough to really have your diagnosis in mind. Although oral and genital ulcerations can be seen in a handful of conditions, such as STDs, for example, recurrent ulcerations in both areas are characteristic of a certain condition, especially when the ulcerations present as they do in this image. The fact that they're 0.5 centimeters, shallow, white ulcers, similar to aphthous ulcers in appearance, really allows us to narrow down our diagnosis. Based on the presentation of these ulcerations, the locations they're found, and their recurrence, we know this patient has B, Beckett's disease. Now, this is a multi-system disorder that is an abnormal immune process triggered by an environmental or infectious antigen in a genetically predisposed individual. The highest prevalence for this condition is in Turkey, Japan, and Eastern Mediterranean countries, and it's actually much less frequent in the US. The classic triad for this syndrome is oral ulcerations, genital ulcerations, and ocular disease, and we know our patient currently has at least 2 of the 3. The oral involvement is similar to aphthous ulcers, occurs in 99% of cases, and is actually the first manifestation of the syndrome in up to 75% of cases. They are very commonly seen on the soft palate and oropharynx, are variable in size, but typically small like our patient's lesions. They have ragged borders and a large zone of erythema. The genital ulcerations appear similar to the oral ulcerations and occur in 75% of cases. The ocular disease component occurs in 70% of cases and includes conjunctivitis, corneal ulcerations, and other problems. This disease can also cause cutaneous lesions, as we see in our patient, arthritis, CNS involvement, cardiovascular problems, GI problems, muscular problems, pulmonary problems, and renal problems. So it is a systemic disease for sure. Treatment for this condition is topical or systemic immunosuppressive therapy, and the prognosis is generally good depending on what organs are affected. Although this is definitely the correct answer choice due to our patient's recurrent painful oral and genital ulcers, as well as their cutaneous lesions, let's go through the other answer choices and discuss what they are and why they're incorrect here. We'll start with Reiter's syndrome. Now, this condition is also known as reactive arthritis, and it occurs because of an infection typically in the intestines, genitals, or urinary tract. This condition affects men more than women, and the symptoms typically appear 1 to 4 weeks after exposure to the triggering infection. Clinically, the knees, ankles, and feet are the most commonly affected joints, and other symptoms include inflammation of the eyes, skin, and urethra. This can occasionally also cause other symptoms that include mouth sores and a rash on the soles of the feet and palms of the hands. Treatment for this condition depends on if the original infection is still present. If it is, then antibiotics will be prescribed to eradicate the bacteria. If not, then NSAIDs and steroids are typically the treatment for the symptoms, and the condition tends to go away within 12 months. Now, although this rarely can cause oral sores, this is not one of the major common symptoms seen in Reiter's syndrome, and it also does not present with the genital ulcers we see in our patient. Our patient also does not present with any joint pain or stiffness that is characteristic of reactive arthritis, and there is not inflammation seen in our patient's eyes, skin, or urethra either. There's also no mention of a recent bacterial infection that may have triggered this reactive arthritis to occur. Because the presentations are different, we know this answer choice is incorrect. Next, we have systemic lupus erythematosus. Lupus erythematosus is the most common collagen vascular connective tissue disease in the US, and it comes in 3 forms, but we'll focus on systemic lupus erythematosus specifically because that's the answer choice given here. This condition is much more common in females, and the average age of diagnosis is 31 years old. The condition has a waxing and waning nature, and the initial manifestations are typically a fever, weight loss, arthritis, fatigue, and general malaise. Oral involvement is seen in 5 to 25% of lupus patients, and these typically present as lichenoid ulcerations on the palate, buccal mucosa, gingiva, and vermilion zones. This condition also typically presents with this characteristic butterfly rash in the malar or cheekbone area, sparing the nasolabial folds, and you can see that in this image. The condition also presents with skin lesions that flare with UV exposure. There are a number of other less common manifestations of the condition that can certainly be seen as well. Renal symptoms, heart issues, headaches, hematologic symptoms, but they're not seen here. Because lupus can involve a number of symptoms and often presents very differently between patients, it can be hard to diagnose. Treatment varies based on the specific symptoms and presentations, and the prognosis is also dependent on what organs are affected. But how do we know this answer choice is incorrect? Lupus can present with oral ulceration in some of the cases. Now, although lupus can present with these ulcerations, they typically present in more of a lichenoid manner than like aphthous ulcers like we see here. Lupus also does not present with genital ulcers in tandem with these oral ulcers and typically does not cause cutaneous lesions to form on the neck or arms. Lupus is also 8 to 10 times more common in females and would present with symptoms that our patient is just not experiencing, like fever, arthritis, and that characteristic butterfly malar rash, as well as those other possible systemic effects we talked about earlier. Because he is not experiencing these symptoms and because some of his symptoms are not seen in lupus, we know this answer choice is incorrect. And finally, we have Stevens-Johnson syndrome. This is an immune-mediated process that is similar to erythema multiforme, but it involves at least 2 mucosal sites plus the skin, usually on the trunk. This is almost always triggered by a drug reaction, is typically seen in younger patients, and it involves less than 10% of the skin. It becomes a different condition when there is more diffuse skin involvement. Within 2 weeks of exposure to the drug, the skin will slough and these flaccid bullae will develop. Patients may appear badly scalded and are actually usually treated in the burn unit because of this, so it gets pretty severe. Treatment for this condition involves discontinuing the causative drug, IV rehydration, and anesthetics or analgesics for pain. The mortality rate is relatively low, which is good for this condition, and if the patient survives, the skin typically heals in 3 to 5 weeks but can scar. Now, we know this was not the correct diagnosis because it presents very differently. Although Stevens-Johnson syndrome does include oral involvement, it presents as more of oral erythematous patches that undergo necrosis and result in large, shallow erosions and ulcerations. It would not look similar to the aphthous ulcers that we see in Beckett's disease. The cutaneous lesions also present very differently. Beckett's disease does not present with the widespread skin blistering that we see in this condition. Genital ulcers are also not seen in Stevens-Johnson syndrome, so we know this answer choice is incorrect. So whenever we see a patient with recurrent oral ulcers presenting like aphthous ulcers alongside recurrent genital ulcers, we know that the patient has Beckett syndrome. We have a 17-year-old female who says, "My teeth are not coming in." She has multiple gastrointestinal polyps, and the cause is unknown, and a panoramic image shows multiple odontomas and supernumerary teeth, as well as multiple osteomas, and her upper first and second premolars have not yet erupted. And we're asked, what is the most likely cause for these findings? Now, we're looking to make a diagnosis for this patient based off of lots of information given in the patient box. We honestly could likely make a diagnosis based off just one or two of these clues, so all of the information given should really allow us to narrow it down pretty quickly. The first huge clue is the fact that the patient has multiple gastrointestinal polyps. This is a pretty unique finding, especially for a condition that also has dental impacts, so we know to be looking for some kind of polyposis condition. Another big clue is everything that we're seeing in this panoramic image, or being told about in this panoramic image. It's basically 3 clues in one: multiple odontomas, supernumerary teeth, and multiple osteomas. The final clue is the fact that the patient's teeth are not coming in or having delayed eruption. Now, when thinking of a condition that results in gastrointestinal polyps, odontomas, osteomas, supernumerary teeth, and delayed eruption, that's a pretty long list of symptoms. It's pretty specific. So we know that the only possible answer choice would be D, Gardner syndrome. Now, this is an uncommon autosomal dominant polyposis syndrome that is highly penetrant. Clinically, it's characterized by multiple osteomas, epidermoid cysts, desmoid tumors, and most significantly, the development of precancerous polyps of the colon. These intestinal polyps develop by the second decade and ultimately transform to adenocarcinoma. The syndrome also has dental effects, which include impacted teeth, the presence of supernumerary teeth, and odontomas. Treatment for this syndrome include prophylactic colectomy, removal of cosmetically problematic cysts and osteomas, and genetic counseling. The prognosis is unfortunately guarded due to the development of those adenocarcinomas. Now, we knew this was the correct answer choice because it was the only answer choice that causes all of those symptoms. It causes those gastrointestinal polyps, those odontomas, those osteomas, the supernumerary teeth, and the delayed eruption. But let's go ahead and go through the other answer choices and discuss what they are and why they would be incorrect. And we'll start with Peutz-Jeghers syndrome. Now, this is a rare developmental condition usually noted in childhood. It's usually an autosomal dominant inherited mutation, and it's due to a mutation in the STK11 gene allowing for uncontrolled cell growth. Clinically, it presents with benign polyps of the gastrointestinal tract, and it can cause bowel obstruction due to intussusception, which is just telescoping of the proximal segment of the bowels into the distal segment, so it telescopes into itself. Now, these polyps unfortunately lead to patients with this syndrome having an 18 times higher risk of developing cancer. Oral manifestations of this condition include hyperpigmented brown or black macules of the lips and oral mucosa that may fade with age, and you can see them in this image. Treatment for this includes genetic counseling for the parents and patients, and to monitor for that intussusception and tumor development. This answer choice may have been a little bit tricky because it's also associated with gastrointestinal polyps, but we know it was incorrect because it has no association with odontomas, with osteomas, with supernumerary teeth, or delayed eruption of the teeth. The patient also does not have the characteristic brown or black oral macules, so we know that this answer choice is incorrect. Next, we have ectodermal dysplasia. Now, this is a developmental condition, which is a group of inherited disorders in which 2 or more ectodermally derived structures do not develop normally or fail to develop. This condition has several patterns of inheritance depending on the type and is characterized by hypoplasia or aplasia of the skin, hair, nails, teeth, and sweat glands. Clinical features include fine, sparse hair or light-colored hair, periocular hyperpigmentation, heat intolerance due to a lack of sweat glands, protuberant lips, a prominent forehead, varying degrees of xerostomia, brittle nails, hypodontia or ligodontia, abnormally shaped crowns, and teeth with conical roots. There's a lot of symptoms, but they all are due to ectodermally derived structures. Now, treatment for this condition includes genetic counseling for patients and parents and will likely include fixed, removable implants, and orthodontics depending on the individual case. Now, we knew this answer choice was incorrect because it's not associated with any of the findings seen in our patient, like the polyps or the tumors. Our patient is also not exhibiting any of the characteristics of ectodermal dysplasia, and she actually has supernumerary teeth instead of missing teeth, hypodontia, which is usually seen in ectodermal dysplasia. So we know this answer choice is incorrect. And finally, we have Down syndrome. Now, in babies with this condition, they have inherited an additional chromosome at position 21, so it's known as trisomy 21. So they don't just have a pair, they have 3. This syndrome is seen in 1 out of every 691 births, and the risk for this syndrome increases as the age of the mother increases as well. Symptoms of this condition include a flattened face, almond-shaped eyes that slant upwards, a protruded tongue, a short neck, mild to moderate intellectual disabilities, musculoskeletal and movement problems, congenital heart disease, and shorter than average height. Dental problems associated with the condition include delayed eruption of both dentitions, hypodontia and microdontia, macroglossia, malocclusion due to a small maxilla, and an increased risk for periodontal disease. Treatment for this condition involves a multidisciplinary team, and it's based on each individual's physical and intellectual needs. Now, although this condition also presents with delayed eruption of the teeth, it's not associated with any of the other symptoms seen in the patient, like the polyps or the odontomas or the osteomas. Our patient also does not exhibit the physical characteristics of Down syndrome, such as that flattened face or upward slanting almond eyes, so we know that this answer choice is incorrect.